Yeah, you can see my presentation?
Yes, sir.
Yeah, yeah. Thank you, Dr. Anaga, and thanks for ARC and particularly Dr. Srinivas and Chitra for giving me opportunity for including me as a part of this wonderful program. So we'll start with the managing posterior segment trauma. Basically, any open globe, your primary goal is to restore normal anatomical relationship to the extent possible to avoid infection also, and then probably later on you can plan. So basically, approach is, if possible, you do a primary repair. That's the standard approach where you want to restore anatomical integrity. And during the second sitting, you probably take care of other trauma-related pathologies. As against what is meant by primary combined surgery, where you do primary repair along with other comorbidities or other pathologies you treat at the same time, try to manage everything during one sitting. Well, another definition when you talk about combine or like basically customary to discuss when you talk about anterior segment trauma, we discuss separately, posterior trauma, we discuss separately. However, most of the injuries involve part of anterior and posterior to a variable degree, and generally a watertight division may not be appropriate. So by definition, you also still can call it as a combined approach. And yes, and if you manage combinedly both the segments, generally that major advantage is reduced hospitalization, rehabilitation time, and overall cost to the patient. So now when you do traditional stage approach, basically because where they do not have a VR facilities available, so you don't have choice, you do a primary repair and send the patient to your VR colleague, or there are certain specific reason why you want to do surgery in a stage manner, that is a planned one. So we'll see both one by one. So now this stage procedure, you divide generally grossly into early, delayed, or late. So generally, when you want to do early second stage surgery is when you have a something like infection, you have reactive foreign bodies, lens vitreous admixture. Now the advantage is there are less chances of inflammation and development of epiretinal tissue, but there is an increased risk of intraoperative bleeding because of active inflammation. You have difficult in PVD induction, clot is still there, so difficult to separate and remove, and significant media age, so vitrectomy visualization can be an issue. So typically what we do all is a delayed management. The second stage is delayed by 7 to 14 days. The advantage is it permits further diagnostic evaluation, better treatment planning. Surgery can be performed under optimal operating condition and rather than doing an emergency situation. And it most importantly help us to discuss the prognosis, nature of the condition disease with the patients and their relatives. The advantages, yes, partially wound healed, so reduce risk of leakage, spontaneous closure of posterior injuries, reduce congestion, so less intraoperative bleeding. So corneal edema, hyphema has probably reduced, so media clarity, so combined or extensive procedure, we can avoid it at that time or may totally avoid it, and probably PVD would have occurred. So all VR surgeons all know when PVD is there, surgery becomes significantly easy. And if your clot lysis is there, removal of the blood can become again easier. But yes, there is additional risk of either developing RD if it's not there, or if RD is there, increase the risk of PVR as well due to secondary fibrous proliferation and excessive scarring. The third or delayed window, what we talk about, generally it is after 2 weeks, and mainly it is particularly, especially for optical reasons where you want to have a vitrectomy for non-clearing hemorrhages, optical PK, removal of cyclitic membrane, secondary IOL implantation, and so on. So when thinking of combined primary repair and vitrectomy, so there are certain definite indications, like you have, as I said, active inflammation, reactive foreign body, infection, lens disruption, and traumatic retinal detachment. Probably this is a scenario here, unless you take care of vitrectomy part also, probably inflammation may not subside, and there is probably increase the risk of even infection if it is there, further worsening. The goal of vitrectomy here is to remove as much of vitreous as possible to reduce the scaffold for inflammation. Thereby fibrosis and epiretinal proliferation can be reduced. And most important thing, what you look at it here, apart from of course PVD induction, and you want to have a good base excision if possible, but you want to clear the vitreous from entry and exit side, particularly that bridging traction has to be relieved, otherwise it can act as a scaffold for further proliferation. However, there are difficulties, as I said, if you have inflammation of adnexia, suppose like this, what you have, exposure for a surgical field will be difficult. associated corneal edema, media opacities. Again, visualization for vitrectomy will be difficult. Persistent wound leakage, hypotony, globe distortion. Technically, vitrectomy again become difficult. May need to combine with PK or patch graft and so on, other additional procedure, which during second procedure, if you do as a stage manner, probably you could have avoided. No clot lysis. So again, as I said, difficult blood removal and obviously increased risk of intraocular hemorrhage. Same thing what we have in early 3-day stage. So coming to PK as a combined, generally as far as possible, primary setting PK is almost always we try to avoid, except certain indication we have a significant corneal or sclerocorneal tissue loss where you cannot approximate the tissue, or you have very badly macerated tissue where again you cannot do approximation or suturing will not be possible. Okay, you may need in this scenario corneal, scleral or sclerocorneal patch graft, which we combine with a probably temporary keratopostosis. When you have retinal detachment associated with, it can be generally either can be traumatogenic or tractional, and most likely is primarily due to injury. The scarring comes usually a tractional detachment as a delayed onset presentation, and aim here is to obviously reattach the retina if it is detached, or probably you want to remove the scaffold, thereby if retina is not detached, you want to prevent further secondary detachments. So there is no agreed time to operate these eyes, but when detachment is there, early surgery is preferred. They generally have associated intraocular or even subretinal hemorrhages, as you see here with the PFCL injected, and you can see through the peripheral break, this you can see the blood is getting squeezed out in the vitreous cavity. Sometimes you need retinectomy if there is a incarceration, and silicone oil would be preferred tamponade in these eyes. Now, ultimately, final outcome depends on how you handle this cornea, ciliary body area, lens, and central retina. So, coming to corneal haze and vitreous surgery, basically various causes as I narrated here. Basically, what happens if you have this opacity like this is definitely compromised, as you see here during surgery because of visualization is compromised, and also even final visual outcome also will be compromised. Now, how you would like to manage this? Ideally, again, as I said, you want to delay surgery as far as possible. But again, management depends on nature, extent, and need and urgency of posterior segment manipulation. So, if you have a corneal edema, blood staining of the cornea, it can be observed. If posterior segment repair can wait, so that will help to reduce the edema, and you can prevent maybe PK at a later date. Okay, otherwise here you will have to combine with a combined PK. If you have a peripheral segmental corneal scarring, something as so, then probably wide angle visualization system help you to complete the surgery. We'll come to that little bit later. Or sometimes if you have corneal epithelial haze, you need to differentiate between, as you see here, or early decompensation. And this type of surgery, though they look bad, you probably can just deabride the epithelium, and surprisingly, you will be able to complete your surgery without doing the corneal grafting at this stage. This is one of the cases. Initially, what you feel like you may not be able to manage this case. This is a post-RK, scars open up, we suture it. And as your surgery proceeds, if you see here, visibility become more and more clear. Obviously, we ask for a PK backup. Cornea surgeons are ready here. And as you clear the vitreous hemorrhage, as you see, retina can look very well. And I could complete entire surgery without PK. Of course, the second sitting PK, we plan at a later date. And this is what you see the view. And this is probably you see here subsequently, as you see laser mark also, we could complete this surgery without doing PK, though which was initially thought we may not be possible. So indications for combined PK and vitrectomy, where you have a opacity which prevents you to see inside the eye before vitrectomy, or you can have associated infiltration, infection, as you see here. Probably here you will, like as you see here, we did a scleral patch graft along with vitrectomy procedure. And this is another Dr. Lalit Verma has shown one video as far as combined procedure, I mean with infection. This is something like you can just remove the corneal button and put this is what is there's a prosthesis here, suture over the cornea, suture over the whatever bed as you created here. This is a central fibrotic lens matter, it was removed. These are two different cases, let me tell you. And this is just showing the procedure, what exactly happened. This is a bimanual dissection I was doing. This as a 20 gauge dissection, both the cases, because I was wanted a long infusion cannula, and we do not know exactly what we are dealing with. And once surgery procedure is over, you remove this prosthesis at the end and suture it with a corneal graft. So now the factors which affect graft survival, definitely quiet eye is the best situation for graft survival. If you do not do PK or you plan after removal of the oil in eyes with attached retina, preoperative good vision, and eyes where you do not need further surgery, survival of graft is much, much better. Endoscopic vitrectomy, I won't say it is an evolving tool. Basically, it was there in hope since long, but because now with the time, we have better light sources, illumination sources, wide beam, and multifunction instrument. So more and more cases, endoscopic vitrectomy, we are using these cases, and that will help you to prevent or minimize the risk having a corneal procedure as a primary procedure during vitrectomy. So that gives a better prognosis. Also, it cut down the significantly surgical time. So overall functional prognosis will be better. However, there are certain limitations. I won't say disadvantages because it's a unilocular limited view. There is a basically lack of stereopsis, difficult orientation sometimes. By manual surgery, it does possible now because you have a chandelier you can use and can work out. And definitely there is a learning curve when you deal with this. Coming to lens, there are variable. You can have a cataract, you can have subluxation, you have dislocation, you have damaged capsule, and with a combination of coexisting iris and corneal damage, as you see here. So basically, poor visualization causes for the surgical intervention. Now, if you have a capsule is intact and not hampering your visualization, probably I would suggest to go ahead with a vitreous surgery first, plan your cataract surgery during second sitting. But eyes with amyloidogenic younger age group, what we talk about, and probably in that scenario, you probably do a cataract surgery at the same sitting. But if cataract is preventing your visualization, you do not have a choice but to go ahead and combine cataract surgery along with vitrectomy. The approach can be pars plana or phaco, depending on case to case. You need to take a call. So if there is, as I said, but also if there is a definite capsular disruption, you will have no other choice but to go ahead with lens removal. Again, depending on how the capsular integrity is, you can combine with IOL or SF-IOL, or you can leave FAK can plan your IOL implantation in a second sitting, something like that. The advantage of delaying IOL implantation is, as you see here, we delayed what have we done? Fibrosis of the capsule. I could wash this lens matter, release the synechia, posterior capsule was intact here. So I could implant IOL within the capsular bag, which probably I would not have been done if I would have done this lens removal during primary setting. What I did here is I cut the central opening in the posterior capsule also to get a bit clear visual axis. So this is another case, combined surgery. You can have, because of time lag, I avoided video here. Iridodialysis repair, what you see is a sequential stage in the same surgery. Repair is done and subsequently IOL implantation and followed by vitrectomy. Everything is done in the same sitting to save time and give excellent results. Suppose you have a pre-existing IOL. Yes, if it is an anterior chamber because of impact of injury, if dislocated subluxury in an anterior chamber or in a subconjunctival phase, obviously remove it during primary surgery. If it's gone in a vitreous cavity, probably you can combine with a second stage as when you are planning vitrectomy. Coming to raised intraocular pressure, there can be various causes. You can have hypema, outflow obstruction because of inflammation or debris blocking the trabecular meshwork, lens induced because of lens matter blocking thing, damage to the angle structure, extensive peripheral anterior synechia, fibrous ingrowth. So depending on etiology, the presentation of the glaucoma, will be varied, and a patient will report at a different time frame. So but what is important is as far as possible, avoid filtering surgery. Rather, is almost never done along with a primary wound repair because invariably it fails because of excessive fibrosis, and try to manage intraocular pressure control by medical line of treatment. So indications for a glaucoma surgery as a second sitting, as I said, like a pre-existing glaucoma if is there and there is significant damage to the optic nerve pre-existing, or if IOP is not getting under control with extensive medical line of treatment. So choice of procedure, again, case to case, it will vary. I won't go in a detail here because that we have to leave with our glaucoma colleague to handle. Dr. Chitra is going to talk about that later on. And also, if necessary, glaucoma procedure as a second procedure, you can combine with a lensectomy, vitrectomy, sterile fixated IOL, and if necessary, along with even iridodialysis repair as well. The word about orbit and adnexal surgery, generally, if you have eyelid laceration, generally, though it can be delayed, but we can prefer to repair lid laceration during your primary repair but orbital fracture and foreign body or muscle desensitization and entrapment can be dealt with at a later stage. Just to conclude, every trauma case is unique and needs individualized treatment plan. There is need to look at the eye in toto. With advances in vitreous technique, there is a dramatic improvement in overall prognosis, both anatomical and functional. Primary repair should never be delayed, waiting for availability of VR setup. Stage procedure with a reduced inflammation offers time for better assessment and planning with a better final functional anatomical outcome. However, many areas still remains undefined. Again, as I said, case to case, we need to take a call. But what is important is clear explanation regarding cardiac prognosis, need for additional surgeries, need for abandonment if unsalvageable, or evisceration consent. All this to need to be discussed with the patients and relative in detail before you take the patient for surgery. Thank you very much for your patient hearing. Most importantly, don't give undue high and better prognosis and do not hype it. That's the message I would like to convey through this. Thank you so much.
Yeah.